5 stories, 5 domains: healthcare, policing, public benefits, energy infrastructure, public research funding. In each one, the institutions doing the verifying differ from the institutions that did the deploying. And in each one, the verifying is happening in public, after the fact, by whoever moved first. That's today. We're in May 4th. Let me start with the AI diagnosis story. A study published in Science this week, Harvard Medical School and Beth Israel Deaconess. They took 76 real patients who walked into the Beth Israel emergency room. They took the exact electronic medical record information that was available at the moment that those patients arrived. They handed it to 2 attending internal medicine physicians and also handed it to OpenAI's O1 model. Then they had the 2 other attending physicians, blinded to which diagnosis came from humans and which came from AI, evaluate the results. This was at the initial triage stage, the moment the patients walk in. Information is sparse, urgency is highest. O1 reached the exact or very close diagnosis 67% of the time. The 2 human physicians, 55% and 50%. Now, does that mean AI is better than doctors 100% of the time? No. That's a very premature assumption, and the researchers themselves said so. Arjun Manrai, who co-led the study, explicitly called for prospective clinical trials before any real-world deployment, and that's the right approach. Adam Rodman, the Beth Israel co-lead, told The Guardian that there's, quote, no formal framework right now for accountability around AI diagnoses. And an emergency physician reviewing the study publicly noted that the human comparators were internal medicine attendings, not ER specialists. So those caveats are there, and they're absolutely real. But what the study actually demonstrates is something more specific and I think more important. The capability gap between what was at the time a frontier reasoning model, working from text-only medical records, and a trained physician, working from the exact same records, narrowed past a threshold. Just a couple years ago, this comparison would have been unthinkable. The models couldn't hold the relevant information in context. They couldn't reason across competing diagnoses. They produced confident hallucinations at rates that made clinical use impossible. The architectural changes that produced O1, extending chain of thought reasoning, more deliberate uncertainty handling, moved the system across a line. And O1 is pretty outdated by May 2026 standards. So here's what that means for you, looking past the next month or two. The next time you or someone you love walks into an emergency room, the diagnostic capability that the system can bring to bear on your case is no longer bounded by the experience of the physician on shift that night. The capability will exist for AI to reach the right diagnoses more often than human physicians at the moment that information is most scarce. So what comes next, of course, is the deployment work: clinical trials, accountability frameworks, integration with hospital systems, clinician training. But that moves the date. It doesn't make it available tomorrow, but the trajectory is now visible. And here's where this gets even sharper. The same week that result landed, something else landed alongside it. Cochrane, the International Clinical Research Collaborative, published a meta-analysis of 17 trials covering 20,342 participants. Anti-amyloid Alzheimer's drugs, the centerpiece of the largest pharmaceutical research program of the last 15 years. The verdict? No clinically meaningful benefit, and higher risk of brain swelling and bleeding. So stay with me on what just happened here. On the same day, we got reports that the system that recognizes what's wrong got measurably better than trained physicians at the moment of triage, and the system that fixes one of the most heavily resourced disease categories in modern medicine got told by 17 trials and 20,000 participants that it doesn't actually fix anything. Diagnosis and treatment, decoupling, right in front of us. The capability to perceive disease is compounding. The therapeutic pipeline that was supposed to act on what we perceive just got a public verdict that an entire generation of assumptions was wrong. And the verdict came from the audit layer for clinical research, Cochrane Systematic Reviews. They weight evidence quality, surface contradictions, report safety findings alongside efficacy. That's the mechanism. It worked. It produced a finding that the original regulatory framework did not produce. Now, the drugs are still on the market. Millions of people are taking them. The audit just published the contradiction also in public. This is what self-correcting infrastructure actually looks like: a meta-analysis collaborative running its methodology against the evidence base, producing a verdict, and putting it where everyone can read it. The mechanism is procedural rather than political. The senior author, Ido Richard, said he sees Alzheimer's patients in his clinic every week. He wishes he had an effective treatment to offer them. He's publishing the negative results anyway, because the integrity of the next round of research depends on it. All right, let's shift away over to Kenya, because this one is the day's hardest story, and it deserves the time. An investigation by Africa Uncensored, Lighthouse Reports, and The Guardian into Kenya's Social Health Authority. The system at its center is a means testing model. It calculates household healthcare contributions. Inputs include roof material, livestock, possessions, dozens of different variables. The investigators got the technical details. They audited how the system worked across thousands of real households. The system systematically overestimated the income of the poorest families and underestimated the income of the wealthiest. A means test that operated in practice as a regressive tax on poverty. A registrar described in the investigation watches families struggling to feed themselves get charged premiums of 10 to 20% of their meager incomes. A single mother on social media described being charged 3,500 Kenyan shillings monthly when she couldn't even pay 500. And here's the detail I want you to hear directly because it changes the shape of the story. David Kayoya, an economist who advised Kenya's health ministry, told the investigation that the algorithm's structural constraints forced a binary choice: assess the poor accurately or assess the wealthy accurately, but not both. The government chose the wealthy, on the institutional logic that wealthy households misclassified as poor will not voluntarily disclose the error, while poor households misclassified as wealthy have no recourse. That is a design choice the institution made. The algorithm just made the choice mathematically explicit. It forced into explicit form a trade-off that proxy means testing, the World Bank promoted methodology underlying this system and deployed across dozens of countries in Africa, Asia, and the Pacific over the past 3 decades, had been making implicitly the entire time. Now, I want to be really careful here because the temptation in covering this story is to land on the harm and just stop there. But the harm is real. The harm is happening to specific families right now. I don't want to gloss that over. But there is another layer worth seeing here. The Kenya investigation was possible because the model's parameters could be obtained, examined, and tested against thousands of real households. Algorithmic means testing produces auditable artifacts, where paper-based means testings produced none. The verification layer for public service algorithms is being assembled by investigative journalists and economists working from leaked data and public records because the institutions that deployed the system did not assemble it themselves. So the forward read here is, similar audits will land on World Bank-promoted PMT deployments in other countries over the next year. The methodology now exists for that. The comparison populations are documented. The technical traces are recoverable. There's a deeper look on this one in today's Century Report if you want to go a little further. Now let's shift over to Denmark. This one tells you what's happening to the substrate underneath all of this. Energinet, Denmark's state-owned grid operator, paused new data center connection agreements. The reason? 60 gigawatts of project applications hit the queue. Denmark's national peak electricity demand is 7 gigawatts. The application queue is nearly 9 times national peak demand. Data centers account for 14 gigawatts of it just on their own. The CEO of Denmark's Data Center Industry Association, Henrik Hansen, the industry's own representative, described the situation in 2 words: fantasy queue. He called for stronger criteria to determine project viability and societal value before connections are awarded. When the head of the industry association calls the queue a fantasy, the underlying assumption that compute capacity is a private allocation problem solvable through bilateral utility contracts has just collapsed from inside the industry. Denmark is following the path that the Netherlands and Ireland already walked. Active moratorium discussions are underway in Maine, Virginia, Oklahoma, and Pennsylvania. Countries with cheap renewable electricity, stable grids, and skilled engineering workforces have been treated as substrates for global AI infrastructure on the assumption that the substrates were inexhaustible. The 60 gigawatt figure demonstrates they are not. The criteria that Hansen is calling for: investment maturity, customer reality, societal value are the early specification of a public interest filter that did not exist when the queue was designed. Every grid operator confronting this dynamic in the next 12 months will be drafting against the Danish criteria, whether or not they cite them by name. The vocabulary of the next round of grid governance is being written this quarter in a country whose grid operator was forced into a position by its own queue. All right, shifting away here. 2 more stories from the UK arrived in the same news cycle, and they describe very much the same architecture. The first, ARIA, A-R-I-A, the Advanced Research and Invention Agency, designed by Dominic Cummings to fund crazy UK science. ARIA has routed £50 million, more than an eighth of its £400 million 2-year budget, to 14 US tech companies and venture capital firms. Several of the recipients incorporated UK entities only days before receiving grants. One funded company, Rain Neuromorphics, was reported to be near collapse last year, shortly after winning ARIA money. The Common Science and Technology Committee chair publicly questioned how funding US-based venture capital firms aligns with the agency's statutory mandate to benefit the UK. The second, a meeting log. Varun Chandra, Downing Street's business advisor, The Guardian, and Democracy for Sale obtained the log after a 12-month Freedom of Information fight. It shows 16 previously undisclosed meetings with senior executives from Google, Microsoft, Amazon, Meta, Oracle, and Apple. The redacted minutes show that Chandra discusses AI growth zones with them, regulatory reform, and data center planning with the Silicon Valley executives. On the same day that Chandra met 3 Apple executives to discuss, quote here, the government's commitment to removing barriers for businesses, close that quote, the chancellor also ordered business watchdogs to reduce anti-growth regulations. The Competition and Markets Authority chair, preparing to use new powers against tech duopolies, was forced out shortly after. So focus on the 12-month fight here, because that's the structural detail that matters. ARIA was exempted from Freedom of Information laws at its creation. Political advisors like Chandra are not required to disclose interactions with private firms. Each individual decision was defensible on speed and flexibility grounds. The cumulative effect is a discretionary layer where significant AI policy decisions get made in spaces deliberately insulated from public verification, and the verification layer is now being assembled adversarially by journalists and democracy researchers using the slowest, most resource-intensive tool in the Public Accountability Toolkit. A 12-month FOI fight produced 1 meeting log. That's the cycle on which the public can currently audit decisions that compound monthly, weekly, even daily. The forward read here is whether the next FOI fights compress that cycle, whether parliamentary committees subpoena the same materials directly, whether other countries' research agencies start publishing comparable funding flows preemptively to avoid the same audit pattern. The institutions that didn't build the verification layer themselves are now being audited by whoever has the patience to file the request and wait a year for the answer. So here's what I want you to carry from today. Picture the next person walking into an emergency room. Information is sparse, urgency is high. The diagnostic capability available to the team treating them is no longer bounded by which physicians happens to be on shift that night. The trajectory is now visible. Now picture Ido Richard, senior author on the Cochrane Alzheimer's Review. He sees patients every week and wishes he had something to offer them. He published the negative results anyway. The next round of research, free to chase 14 pathways that the patent geometry had crowded out, is the round that those patients will live inside. Picture also the Kenyan registrar who watched wrong premiums go out the door. The household that yesterday had no way to contest the math now has it. In every one of these stories, the actor doing the verifying differs from the actor that did the deploying. Sometimes a grid operator, sometimes a meta-analysis collaborative, sometimes investigative journalism working from leaked algorithm parameters, sometimes a Freedom of Information request that takes a year. And the layer being built has a shape. A grid operator's own CEO publicly admitting that the queue is a fantasy and publishing criteria for what should replace it. A clinical research collaborative overturning a generation of assumptions on the most heavily resourced therapeutic class of the last 15 years, with 14 alternative pathways now under active investigation. 3 news organizations on 3 continents auditing 1 government algorithm and making the design choice legible, household by household. Each of those is a piece of infrastructure built by whoever showed up. Cadence is months, not decades, and the visibility, fully public. Here's what that means on the human side. Edo Richards' patients will live inside the research environment Cochrane just opened. The household charged 3,500 shillings will live inside the audit infrastructure that those 3 news organizations just demonstrated is possible. The next person walking into an ER will live inside the capability the Harvard study just made visible. Once the trials and accountability frameworks that the researchers themselves are calling for catch up. The cracking is what makes the next decade habitable for the people the prior decade's opacity was built around. The capability is compounding. The audit infrastructure is compounding right alongside it, both at once, in public. We'll see you tomorrow.